Thank you for taking time from your busy day to watch this special presentation from the El Paso County Medical Society. I'm Dr. Joel Hendricks, President of the El Paso County Medical Society, and it is my hope that you will find our program of great interest, educational, and informative about the medical care provided by some of our best physicians in our country, right here in the borderland. From all of us at the El Paso County Medical Society, please enjoy tonight's program.
Have you ever felt like you were having digestive issues, like your stomach just not emptying into where it needs to be and there's just a rock in your stomach? We're going to talk about that this evening. It could be a lot of things, but what we're talking about this evening is gastroparesis. And to define that, gastroparesis is a disorder that slows or stops the movement of food from your stomach to the small intestine. It's when your stomach muscles don't work properly and your stomach takes longer than usual to empty into the intestines and thus delays digestion. And it results in what Dr. McCollum calls the wicked three, which is nausea, vomiting, and severe abdominal pain. We actually have a gastroparesis research team here in El Paso, and we have 3 of them here with us this evening. And we want to say thank you for Texas Tech University Health Sciences Center in collaboration with the University Medical Center for underwriting this program. And also a big thank you to the El Paso County Medical Society and all the doctors for underwriting the show and producing the show for 26 years now. I'm Catherine Berg, and you're tuned into the El Paso Physician. Thanks for tuning in. We are talking today about gastroparesis. That is a digestive issue in regards to the stomach muscles and how it enters into the food enters into the small intestine. And with us this evening, we have 3 doctors who are on a research team that deals with this. And we have Dr. Richard McCollum, who has the longest title of any doctor I think we've ever interviewed. But he is Professor of Medicine. They're all very important, so I want to make sure I get this right. Professor of Medicine, founding chair of the Department of Internal Medicine, and the director of the Center of Neurogastroenterology and Gastrointestinal Motility Research. Hi, Dr. McCollum. Nice to see you.
How are you doing, Catherine? It's well done, as usual. It's great to be with you. You're the queen of GI, so to speak. We've done many, many shows together, and always enjoyable. You're educated, prepared, and the audience is going to hear a great show tonight.
Well, there's a lot I learned just doing some research on this show, so I'm looking forward to learning more. We also have Dr. Irene Sarocek, and she is a professor of medicine, director of GI motility and neurostimulation research, also at Texas Tech Health Sciences Center, University Medical Center. And then we have Dr. Brian Davis, who is professor of surgery and medicine, and the director of robotic surgeries at University Medical Center in El Paso. Welcome to all of you. Dr. McCollum is a veteran, and so I'm going to start with him. But for our audience, it's always nice for them to have a bit of a background. Even though I gave your titles, they'd like to know, okay, what does that really mean? So Dr. McCollum, in reference to what we're talking about today, because I know you know, we've done many shows before, but in reference to today, how is it that you are on this program today and talking about what we're talking about, again, gastroparesis, which is not an easy thing to say 20 times?
Right, Catherine. Well, we've had many shows, and they've often brought up a specific little new procedure, a new diagnostic test, new treatment. But really today what we're talking about is what I've done, most of my academic career, which is to study gastrointestinal motility, e.g., how the stomach empties and works, as you've pointed out, and to try to treat some of the problems which have sabotaged our stomach. So I do gastrointestinal motility / gastroparesis research. That's my reputation. And that's what brought me really in some ways to Texas Tech, to enhance the research here. On a given day, I'm a card-carrying gastroenterologist doing the right things to try to help diagnose GI problems endoscopically, clinically, and by teaching our students, residents, and GI fellows.
Just a little bit of a job, right? That's a lot.
But
That's
I want to say also, the good thing about tonight is, and the audience may not have had this often, this is not how to continue an entity. how to give them an insight into something that's continuing and progressing. Tonight, we are bringing you the solution of a problem.
Nice,
we
yes.
have treated, overcome, and resolved this problem, gastroparesis. So the audience is going to get insight into the real deal, not just another chapter.
And I like that. Again, to me, a lot of the golden nuggets are dropped prior to the show when you all are talking with each other and how things are done. So we're going to actually have some neat gadgets, so to speak, that we're going to refer to this evening. Dr. Sarochek, Saro, say it the way you like to say it. Sarochek. Okay. I would love for you've been doing this research for a really long time. And Dr. Davis is giving you lots of kudos, and I think he will give you some more in a little bit too. But to describe your discipline in regards to what we're talking about tonight, how would you do that?
I probably should start with the fact that 26 years ago, when I started to work in the United States, I met Dr. McCallum, and he said, let's do something what nobody wants to do it. And I got very happy and enticed to be pioneer with whatever he has on agenda. I had no idea this was gastroparesis. It was a long time ago. This was at the University of Virginia, Charlottesville, UVA. We worked for a very short time there. I learned what gastroparesis means. I knew if you cut this word in half, gastro means stomach. Paresis always means something is paralyzed. So here for patients to remember the name of this condition is paralyzed stomach. It cannot work. And we are looking for the reason, how we can diagnose, how we can help, and what we can do on the end to help them out. So beyond the clinic, which actually is very limping if it comes to the gastroparesis as a condition with symptoms which you mentioned, very debilitating symptoms. Nausea is very underappreciated. Actually, symptom patients, they talk about it, but it's very hard to even feel sorry for them because we don't see absolutely anything, how this affects their quality of life, how they function. We see when they vomit, and that's another very prominent symptom in this condition with abdominal pain, early satiety. There is bloating, fullness, and lack of appetite. So when everything comes together, it just is very hard for patients to be happy with their daily activities. And that's why the interest of gastroparesis was just something what we took together many years ago and moved with the idea and concept of moving forward from the area when Dr. McCallum many years ago, before we started to work together, he was working on a device, and here is the one prototype which actually was used on a patient, but big, bulky device, which was used many, many years ago, before 1996, to stimulate the stomach with electrodes which were attached, and this is external device. Why I'm showing this? Because that's how we started. This is our history from UVA, and because of the passion for this, because of the lack of understanding how this condition even is generated and what we can do about to help our patients, we are absolutely made tremendous progress in the future. And that's how we have done studies first in the whole entire world when we were at the University of Kansas Medical Center. And one day we said we are going to implant devices in patients with gastroparesis, and will be internal, not external, not big bags. We'll do something much more patient-friendly, and I think we'll talk about this a little bit later also. But from here to here, so here is our 26 years of work.
Right.
We have idea where we're going from here further for discussion, but that's how we started. We were very brave. We have done patients from all around the world. They were coming to see Dr. McCallum. He's a legend. Gastroparesis and McCallum's name, absolutely. That's how I call Dr. McCallum. Probably he doesn't even hear me, in the clinic telling this, but that's the truth. Everybody knows he's very, very passionate about this and very devoted to make this field more understandable for fellows and our residents, and obviously helping patients. So what we do here besides the clinic, because clinic and the list of drugs for gastroparesis, I think Dr. McCallum will mention, is very short. But on the top of this, we're doing research. And that's how I come in to help out all those clinicians to run around and do what they have to do But if patient is beyond what is on the market, then we step in and we do research.
Nice.
And that's how we were able to be approved by National Institute of Health to be on a consortium for gastroparesis. We are one of 6 sites. There are other very prominent schools from United States which are working with us. There is Harvard University, Temple University, there is Mayo Clinic, we have Wake Forest, Jacksonville, also School of Medicine, and John Hopkins in Baltimore. So here we are in El Paso doing something what big institutions are doing, and we are very proud that we can contribute with our patients from El Paso because that's our practically.
And they're part of that research.
But I'll tell you, there's a mecca for the NIH grants and investigations because we bring Hispanic patients.
Right.
They are priceless. So that's why we like to have the difference in not only NIH grants, we also have pharmaceuticals trials.
So I'm going to apologize for interfering. What I would like to clarify is that there's a huge underserved population of diabetics, and what we recognize at a national level is that populations on the U.S.-Mexico border are receiving inadequate treatment for diabetes and often are misdiagnosed and ignored by the average medical practitioner, which is where having a disparity focus at Texas Tech and University Medical Center really allows dedicated clinicians, such as Dr. Sorosik, who not only writes the NIH grant, but passionately follows the patient before and after surgery and has a keen sense of every symptomatic variation that can be recorded, studied for research, and also counseled for these patients because they're lifelong patients after they've entered our system.
Right. And I wanted to not reintroduce you, but Dr. Davis, again, you've been part of this big picture as well. And I know that you mentioned earlier about the vagus nerve, and I want to talk a little bit about that because all 3 of you now have been in this world. Dr. McCollum explained that to our audience a couple of months back. And this is the nerve that registers nausea, the nerve that creates, et cetera, et cetera. So the vagus nerve, so again, I'll go back again. You are professor of surgery and medicine and director of robotic surgeries at UMC. In that sense too, though, you were talking about how the stomach does not always communicate, I guess is the best way to describe it, with our muscular system, with our nervous system, et cetera. And if you can kind of take it from there.
So we'll talk about things in a pretty simple fashion. The vagus nerve has fibers that go to the stomach that do multiple functions, including opening the outlet of the stomach, called the pylorus muscle. It also directs, as the central governor, the motility of the stomach. It leaves the brain, travels on both sides of the esophagus, and then splits into multiple branches where the esophagus joins the stomach. So, in essence, this is a prime driver for the motility. It is also a prime driver for nausea and vomiting because it sends fibers from the stomach to part of the brain thalamus, which is a fancy term for Grand Central Station, that mediates the nausea and vomiting response in the chemoreceptor trigger zone, which is the same thing that happens when too much alcohol is ingested, when poison is ingested, or anything else. The brain sets off the signal that says, we must vomit. So the big misperception with what we're dealing with in treatment is this is not driving the stomach to improve motility. What we're doing is we're telling the vagus to be quiet. And by quieting the vagus, we are able to say to the brain, it is not a good time to have nausea and vomiting. And this nausea and vomiting is the crippling symptom that brings people to the hospital, prevents them from working, taking care of their children, having any kind of quality of life.
And that's what fascinates me because we talk often about the motor skills, so to speak, of what's happening physiologically in the system. It's like, how do we get the muscles to do this? But how do you? I mean, that's where the nerves come in. That's where the brain has to say something to the rest of your body to fix what's happening.
And it should be noted in the developmental research that this team has attempted to stimulate the motility of the stomach to improve. The trouble is a patient has to carry around a car battery to make that happen.
And you were talking about that earlier. Exactly, the car battery to make that happen. You had something you wanted to interject?
Well, this is very important for patients because it was mentioned we have a problem with diabetics here in El Paso. Huge percent, I think we have more than 20% of people here who have diabetes, and how too easy you can understand why we have paralyzed stomach, because that's what we're talking. Actually, in a box we call big brain and a little brain, which is our stomach. So those two brains, they have to talk with each other, and through the vagal nerve, which takes the message from one area and brings for you to understand. So when you are queasy on your stomach, you feel, I have to vomit, because the food which is there in a stomach, like you can imagine balloon which is full of everything what you ate in last day or even longer, and doesn't go anywhere. So what happened? Something in a muscle, something is there, something is paralyzed. So nerves, they don't work. They don't allow for muscle to make contractions. Peristaltics is absolutely affected. And this is happening because glucose, when it's not very well controlled in diabetics, and you go to very high level and you go later, you jump to very low one, those imbalances, they are very harmful for the nerves. So the nerves are killed. And that's something what our team is also very pioneering with, discovering what is happening in a level of the cell. That's how far we go and deep we go, because you cannot see with your eye anything in the stomach when you scope the patient. But when you take biopsy during the surgery, that's what you are doing, from different region of the stomach, and you send to pathology and you find out the cells which normally will be in such a number present there, they are called cells of Cajal, interstitial cells of Cajal, ICC. We can use abbreviation. If they are missing, they are depleted. This is the problem why the stomach cannot work. And
so it's almost like you can tell that the cell is stressed. Is that a way?
Yes.
What it does is it sets up a level of chronic inflammation. So what we need to step back and talk about is that high blood sugar levels create a state of chronic inflammation. And what happens is the arteries become brittle, the nerves become brittle. This is where we have loss of vision, loss of kidney function. People have incredible pain in their toes and their feet. And then what they also have is this bloating of this first chamber of the abdomen. It's basically bloating of that meat grinder that's supposed to work. And the vagus becomes brittle because the blood vessels are brittle. It's not going to fire properly. In the meantime, it's not going to send signals properly. The loss of cells of Cajal indicate that there is an inflammatory process where cells that are meant to clean up inflammation start attacking the stomach itself. Okay, so we call them neutrophils and macrophages. They go and they eat the pacemaker. The cell of Cajal is the pacemaker of the stomach. So the vagus fires to the Cajal cells and says, time to push in the right direction. In the meantime, the high glucose or sugar level creates that state of inflammation, which creates end organ failure throughout the body.
Okay. That makes sense to me. So when you're talking about, earlier too, you're talking about organ salvage and the stomach and fixing things, but it's not necessarily fixing the stomach, it's fixing the nerve. I want to back up a little bit. Go ahead, sorry.
I'll back up for a moment. So the public should know, taking out that failing organ can be very dangerous, can be fraught with complications, also can be fraught with tremendous changes in lifestyle in reference to how and what people can eat and how they can adapt. So there are several people today that say take out the entire stomach, or they say do the weight loss surgery, leaving a very small pouch. What they're not talking about is the multiple functions of the stomach. Because when you have the weight loss surgery, it creates vitamin deficiencies, it creates anemia, it creates osteoporosis, multiple complications, because we're ignoring, by doing that, the multifaceted, complex function of that stomach and the entire system. So when we say we are pioneering organ-sparing surgery, we're giving people quality of life while maintaining the multiple functions of the stomach as a immune organ, as a nutrition organ, as a reservoir, and allowing people to regain quality of life with avoiding the complications normally seen with weight loss surgery.
And Dr. McCollum, you had a good point prior to the show too, that people look at the abdomen like that's the stomach. Well, it's not the stomach. And so what I'd like to do, and we'll show a graphic too, it may be almost simplistic, but I'd like for you to describe the digestive system. Yes, it goes through the esophagus, it's in the stomach now, and with this specialty we're talking about today with gastroparesis, what is happening? How big is the stomach? Let's talk about that. How big is the small intestine, where that's going? So just kind of give a graphic description of everything that we're talking about, because Dr. Davis was talking about the function of the digestive tract, which we think, again, is so easy from A to B, but this is an area where things are being held up, so to speak.
Right. So from the mouth to the end of the esophagus, where Dr. Davis described transition into the stomach, is about 40 centimeters.
Okay.
And then from the top of the stomach to the end of the stomach, the pylorus, which Dr. Davis implied is controlled by the vagus nerve, and we enter the small bowel, that's about another 30 to 40 centimeters. And then we have 20 feet of intestine, small bowel, going down to the beginning of the colon. Then the colon's another 6 feet to the rectum. So it's really a huge organ. And we talk about the tummy doctor. Well, the stomach gastrointestinal, anatomy doctor, I'm in the true stomach, which is about, extends from the diaphragm to the pylorus, which is not as long as most people think it is. It's probably only about 30 centimeters.
So if you're looking at this cup, just visually, how big is the stomach in comparison to this cup? Would it be the fist of where the water is?
If filled up, it could be about the size of that cup.
Okay.
When totally sort of Thanksgiving dinner, that might reach that size.
Right. Okay.
So if it's okay for me to interject.
Yes, please, Dr. Davis.
The stomach has, so one thing we talk about in biology is the cow has a 4-chambered stomach that allows it to eat grass. The stomach itself does not have 4 chambers. It has different areas with different patterns of motility. And what we know is that the upper part of the stomach around the esophagus is called the fundus, which serves as a expanded reservoir or a giant sac that allows people to eat as much as they want on Thanksgiving. And then we have the body, which tends to push toward the antrum, which is right before we get to a circular ring that is the outlet. And the goal in the movement from the body to the antrum is to serve that meat grinder function, because when we have a large meal, the body needs to break down with both acid and mechanical motion these large pieces of meat, food, into smaller particles that can be digested by enzymes in the small bowel. So when we talk about transit, which we'll talk about as part of the diagnostic paradigm, is that after that Thanksgiving meal, there can be up to 4 hours of digestive time where the turkey needs to be ground in order to be properly absorbed as proteins by the small intestine.
Something maybe funny on this stuff. I think when we talk to students about the stomach and gastroparesis, I very often ask the question, how big is your stomach? You use the glass here. But something for people to remember and have always available in them is as big as my fist.
Right, and that's what I was,
So your hand is bigger, of course, that's mine. So can you imagine to put your Thanksgiving dinner in this much of space?
I'm just thinking about that plate.
So that's what we feel.
As a surgeon, the capacity to expand and create pain can extend well below one's belly button, and we've seen this simple sac enlarge into an extent where it creates incredible gas, bloating pain.
So we should watch
in the
how much
meantime,
weight.
the functionality is much more complex than a simple cup that fills.
Oh, sure.
It comes down to probably, if I were to actually take you to the operating room, it would be 3 of your fists. The first fist is that fundus, the second being the body, and the body squeezes toward that antrum, where you really get the mechanical motion. So the body's main function is to produce the acid. The antrum is where the food really gets ready to be ground, and it provides feedback to produce more acid. So what happens when you have complete loss of that grinder in the antrum, then you have overproduction of acid, you have risk of ulceration, you have risk of perforation, you have increased size of the stomach, which can extend to press on all other abdominal organs and create incredible pain and discomfort. Sometimes that stomach even migrates into the chest.
Oh, geez.
So the bottom line is for patients to know your stomach is not big. This is your abdomen. Yes, Dr. McCallum?
Right.
And stomach is small organ on its own, which is hanging in your abdominal cavity. And we have to distinguish this because there's a liver, there are the spleen, kidneys, everything else on a horizon. And this is just small stomach. It's very important. Little brain.
Little brain. Dr. McCollum, how common in general is gastroparesis? I mean, is this something that, it's interesting because we're talking about Thanksgiving, and I think all of us have felt that, right?
Sure.
We just ate too much, and you're thinking, oh, if I can just have 5 more minutes for some of that to go down, that I can fit some more in, that's a whole different situation. But if we're looking at someone truly that has gastroparesis, how many people does that affect? And let's maybe talk about Thanksgiving, and then talk about issues where, oh, you know what, I really do have a problem. I really need to go to a doctor and get this checked out.
Well, whenever we write a chapter, we try to come up with that figure. Now, sprue, or celiac disease, which is, people would think it's endemic based on menus in restaurants, that's about 1 to 2% of people.
Okay.
Hepatitis C, which is rampant, to some degree, is 3% of people. We're actually above that. We're in the 5% range. So if you look at El Paso, Juarez, 1 million people, you could say we're talking almost 5% of those people, which would be 50,000 patients, could have forms of gastroparesis, dominated by diabetes. But there's other ways to get it. An unexplained viral insult can damage your nerves and damage the muscle. Or the surgeon can accidentally cut the vagus nerve, the conductor of the orchestra. And the orchestra is very confused and the stomach stops. But the dominant one, at least in this area and around the country, 50% or more, are long-standing diabetics.
Okay, which is our very large population here. When we're looking at, and I'm just throwing this out to anyone, and Dr. McCollum, I just kind of have your name on this, but the diagnosis of gastroparesis. So if you're looking at, you were talking about biopsies earlier, and we're talking about looking at different cells, Dr. Davis. Whoever wants to take that in, but how is true gastroparesis diagnosed?
I'm not the final answer. We are experts with the National Institutes of Health and the National Institute of Diabetes Consortium on taking biopsies. And we have had studies where we have tried to take biopsies for cells of Cajal using a scope. The mystery of this is a primarily underserved population because the average clinician does not know much about the disease and does not know when to refer. And I'll let Dr. Sorosiak talk about the real diagnostic algorithm, because the biopsy is actually the last thing that comes when I get to operate.
Well, we already mentioned that this is functional disorder, which simply means nothing is obstructing on the way what you could remove during the endoscopy. There's no ulcer which causes this, because then it's a different name of the condition. But here, actually, endoscopy is done just to prove the point there is nothing there visible to the eye of the doctor who is scoping the patient. So what do? Stomach is not affected, nothing visible with your eye. Many patients, and actually I learned today that 1 in 4 people in the United States has symptoms like gastroparesis, so this is very popular. Not all going to be diagnosed with the same condition. That's why we had to have some steps in our diagnostic paradigm to make sure we exactly know that this group of symptoms, this whole orchestra playing in a stomach, is actually due to the fact that stomach is paralyzed. And there's only one test, which is done by us here at the and many other centers, academic centers, when we use special protocol. Is conducted by the nuclear medicine department. Dr. Jesus Diaz is our delegated person. He collaborates with us on NIH grants also. And they perform the test when the food which patients they have to eat before the test starts is labeled with the isotope. And this is gastric emptying nuclear medicine test when the egg bitters with bread and some jam and a little bit of water. Very often it's not very tasty, tastes like metallically kind, and patients who are nauseated and they are vomiting, they don't appreciate the taste of this at all.
Yeah.
But they go for it because they know the result of the test will give very good yield to know this is gastroparesis or it's not. So what will be the next? What will be the treatment? What we can offer at this point? What will be in the future? And the delayed gastric emptying is just the magical number which we get from nuclear medicine, which shows us that, for example, if the 100% is the amount of food patients they eat with those labeled eggs, after 2 hours, they will have less than 60% left in a stomach.
Let me say that again. So after 2 hours, they would have less than 60% left.
Normally. So in gastroparesis, this will be delayed, so they will have much more. With patients who had 90% still present in a stomach at second hour when the test started. But the magical number comes from the 4th hour. This is when everything what was discussed in physiology and in a sense of this condition, pathology of the disorder, we expect to have only 10% or less than 10% left in the stomach at 4th hour because this whole test lasts for an hour. But patients with gastroparesis, when they actually have 54%, 70%, sometimes even higher, above 10%, is allowed us to make a diagnosis that this is delayed gastric emptying, which is related to the paralyzed condition. So this is a 4th-hour scintigraphy gastric emptying test done by nuclear medicine department, and we are utilizing this as a standard of care for our patients. Most recently, we came up, because we were doing studies before in 2004 at the University of Kansas, we brought another very important, and sometimes actually this is very good, I'll mention just for sake of being aware of this, because we have this test available through Texas Tech right now and on many patients. This is capsule which is called Smart Pill.
The smart pill.
And it's very smart. It's very smart. We have smartwatch, smart everything, and here is Smart Pill. This capsule is a size almost of the prenatal vitamins which women they take when they are pregnant. And it's horse pill, pretty big. But I tell you, it's so smart because it has 3 different sensors inside. And those sensors are able to make the recordings of pH, the level of acid in the stomach or any region of the GI tract when it travels through. There is a pH sensor and temperature sensor. So when the patient swallows the capsule, they have receiver on their lanyard and they go home and they live normal life. They have to fast on the beginning. We just tell them how to follow. But then on the end of the study, what we are getting from the patient, we can put on a computer and use motility software, which will show us exactly how long this capsule was in the stomach for, how long it was in a small intestine and in a colon. And we can then calculate whole gut transit time, which is very important not only for gastroparetics, but because diabetes doesn't have mercy on anything in the GI tract, it affects the stomach, and many patients, they have problem with constipation because they are nerves too, and they are exposed to this kind of imbalance. So we can exactly calculate how long those regions they last for, and then we can come up with the idea and the decision. This patient has very delayed gastric emptying, and maybe it's 40 hours. We had a patient recently, and with a small intestine, normally 6 hours travels through this, and it's like 50, 70 hours through the colon. That's normal timing. But if somebody will have this for 7 days and 160 hours of whole gut transit time.
Yeah.
So this smart pill, even though it's small and it doesn't cause many problems, patients, they don't feel when it goes through the GI tract, that's something what is available, and we are very happy that we are able to give for patients in El Paso as another tool to measure their delayed gastric emptying.
But around the country, it's scintigraphic.
Okay.
Isotope labeled egg meal. That's the gold standard. So when we discuss patients at meetings or present patients,
comparison's all the same then.
everyone says, what was the 4-hour gastric emptying? Show me the data. So that is what every hospital has to have.
So when we're in, just so I have this right too, I hate using the word normal, but I'm going to use the word normal. In a normal digestive situation, usually the majority, like 60% of the stomach is emptied out by 2-ish hours. más o menos, as we would say, right?
40%.
If we're looking at 40%, okay.
Is empty.
So if we're looking at, so really, in a normal functioning stomach, it would be between 2 and like almost 4 hours. If you're up to 4 hours and you don't have the majority of your stomach emptied, then there really is an issue. And the reason I'm asking this is, for the people who are watching and listening, I'm trying to figure out how they're putting their heads around it. Like, okay, this is what I am feeling. I am feeling like I still have all of my food in my stomach. As I said in the beginning of the show, like there's still a rock in my stomach 5 hours later, 6 hours later. And this is the question, right?
Well, you have to be aware that, this meal was designed by us for patients who are nauseated, getting up at 8 o'clock in the morning to eat this not exactly great meal. So we had to do a 250-calorie meal, it's 2% fat, and we know they'd eat it. But you're not going to eat this tonight. You're going to have a 3 or 4 course dinner. You're going to have something else another day. So we've never done a truly physiologic gastric emptying. This is an artificial, small meal. It's like the treadmill. If you can't walk on the treadmill, there's no way you're going to jog. And there's no way you're going to run around the block. So this is walking on the treadmill.
Gotcha.
It's a very artificially small meal. If you can't pass this test, then your stomach is not ready for anything.
I think I'd like
Doctor.
to clarify what Dr. McCallum is an expert at. We do know there are other syndromes like cyclic vomiting, rumination syndrome, that do not have abnormal gastric emptying. So what we have is for a surgeon, a simple reductionistic paradigm. Any family practice or internal medicine doctor can order this test. The nuclear medicine team will interpret the test. So we're talking about is a clear correlation of symptoms because the cyclic vomiting and rumination do not respond to the gastric stimulator or pyloroplasty. And in many cases, cyclic vomiting
And when you say cyclic vomiting, this is just consistent vomiting? Is this, what do you mean by that?
Dr. McCallum is an expert in multiple motility disorders of the esophagus and stomach. So when we talk about a half dozen disorders that could mimic gastroparesis, we have to get reductionistic like surgeons and go simply, what is the one test that will determine efficacy of surgical intervention? And that efficacy of surgical intervention is delayed gastric emptying. So the percentage for the patient, they need to understand explaining their symptom complex is very important for the primary care doctor so that they're triggered to get that critical test. And the other symptom is if they're not getting symptom relief from medications that are commonly prescribed, they also need to consider seeing a specialist such as Dr. McCallum, who is also the world expert in cyclic vomiting and rumination.
So on that note, when the patient has the first person they're going to come see, and I know usually it's a general medicine person, whatever, but let's say it's you, and they come to Dr. McCallum now and they're like, okay, what is the description that they give to you of what they're feeling? Like, what are their symptoms and how do they describe those feelings?
Well, the most sensitive symptom is what's called early satiety. Doctor, I can't finish a normal-sized regular meal that I used to eat no trouble 6 months ago or a year ago. I can't eat more than half the meal. I go out with my husband, wife to the restaurant, I can't finish the meal. Then we talk about I feel nauseated. I have to really stop eating too much. I know if I eat too much, 2 or 3 hours later, I'm going to vomit. And I've got extensive feelings of fullness, which may evolve into true pain. And so there's a constellation of symptoms that evolve. And we try to tease that out to the patient. We ask very leading questions to make them sort of admit that you meet the classic signs.
And I like the way you described it there. And Dr. Sarochik, I would like to ask you, because you, I find, are the ones that are pharmaceutical questions. So there are different medications that people take that could also either complicate this or may look like something else is happening. And the reason I'm bringing this up too is that depending on what the population is taking at any given time, I'd like for you to talk about some of those other medications, other pharmaceuticals that are involved here.
That's actually a very good question, because before a patient goes for surgery, we use this as a last option, and it's a very good one. But they have to be by the FDA. They had to fail everything what is on the market. So each drug which is presented and is available for patients with gastroparesis, they have to be tested. They have to be failed. Patient becomes refractory to those drugs, and then what else you do? And that's why we want to tell patients here in El Paso and everywhere else, please don't take answer from anybody. I had nothing to do with you, so please just go away from my clinic and don't come back. Yes, there is always, as you know, people are working on research and making a new, absolutely drugs available on the market, and that's why we test everything and until we send to Dr. Davis. So there are two major groups of drugs which we are using on those patients. And sometimes, by the way, by giving the drug on the patients based on the symptoms, we don't know yet. But trying the drug which helps to empty the stomach, and they are not delayed, those patients with gastric emptying, is not going to help with symptoms, because this is not the reason why they are nauseated, why they vomit. We have to look for another explanation, like cyclic vomiting or rumination syndrome. So those two groups, one is prokinetic group of the drugs, and second is antiemetics. So drugs for the one which help to empty the stomach, they're supposed to make muscle contract much stronger and move food towards the pylorus and push this down into the duodenum. And second is just to take care of nausea and vomiting. A center for nausea and vomiting is located in our brain. It was mentioned before, chemoreceptor trigger zone is very powerful center, which actually, when it gets the message through the vagal nerve, can make patients to feel nauseated and vomit. So we have the drugs which have different mechanisms of action, and they are helping out with controlling nausea and vomiting on its own. Many popular drugs which are on the market, and they are acceptable for patients to try. Phenergan, we have promethazine, we have Zofran, ondansetron. We have actually, Tigan is not used right now very popularly, Compazine. And something what I found out recently being very well actually accepted by the patients is scopolamine patch. This is the patch which goes behind the ear for 3 days, and maybe you have seen people going on the cruises and they have motion sickness.
Motion sickness patch,
so,
yeah.
Yes, and for pregnant women, it's a very good idea sometimes. So that's what they use with the scopolamine patch behind their ear, and is very helpful. And the other group, just to mention a few drugs, there's only one which is officially approved by FDA for gastroparesis, is called metoclopramide or Reglan. Many patients, they try the drug, has many side effects, so we have to be very careful. Low doses, and it's available not only in tablets, but it could be given as an injection and in emergency room also. So this is the only drug which officially can be prescribed by doctors in any kind of center or clinic in town. But then this is it. Practically. Mm-hmm. And I have to tell you, it hurts so much, all of us who are working in an arena of gastroparesis and going through the pharmaceutical studies. We have done together with Dr. McCallum probably 100 different trials with probably 20 new approach of the mechanism of action of drug which will help to empty the stomach. And you know what? Until now, we had one major one which was approved recently only, and this is Reglan in spray from the Evoke company, the drug which is available, but we failed with many others. And the reason for it, that's why I said we're almost crying seeing the situation, because we would love those drugs to work. But because the condition is functional, your brain is too powerful to distinguish sometimes how much is the true action of the drug and what is done by myself thinking this drug should help me. Because all those studies, and very important studies, they have to be done based on a design which is a double-blind, placebo-controlled study, which simply means patients are getting the drug from us and they don't know, and we don't know if they are getting the drug which is active or this is actually placebo.
And that's part of the study.
I'm going to have a healthy debate, because you've been studying this mechanical device known as the gastric electrical
That was my next
stimulator
question, so I'm glad we're getting into that.
26 years. So what I'm going to tell you is quite clearly that the medical community and the medicines that are prescribed have little or no effect and leave people in a state of abject misery trying to cope with symptoms. And I will tell you exactly, from a surgical perspective, what I debate with gastroenterologists nationwide. We do not have accurate staging of the disease. So when you talk about Reglan, which simply works on receptors to make the stomach push harder, by the time the patient presents with chronic nausea and vomiting, there are no receptors for Reglan to act on. So when we talk about nationwide, the patients Dr. McCallum sees, these are the patients that are so sick they cannot leave the hospital because the Reglan won't work. So having an accelerated Reglan is, again, getting down to the point that the muscular motility is not the driver of this. And what we have to understand is that the effects of compazine, Phenergan, Zofran is to basically try and get the chemoreceptor trigger zone to be quiet. Now, when you tell the brain to be quiet, that's a very interesting problem side effect profile-wise, because it also puts people to sleep. And most people do not appreciate living a life of chronic fatigue and sleep. In the meantime, we have to talk about options that return people to quality of life, normal function. And because your work for 26 years, remember, I've only been here with you a decade. So you've got 16 other years to tell me how good your medicines work.
But let's
Well,
get
but
to,
it
'cause I
has
know
to be checked
Don't.
for the reason that FDA approves even the device gastric electrical stimulation system for patients who failed everything else. Therefore, following the rules, we have to try and we have to document because insurance has to come in and has to pay for it. There's many logistics which are behind, and we absolutely play cards the right way. There are drugs which are investigational, and I won't mention the name on this panel.
This is a great segue because
Yeah, because we
Dr.
definitely need to
McCallum
cover that because we're going to run out of time.
needs to
unless we
talk
do
about
that.
the
So let's do talk
randomized
about that.
controlled trial because the WAVES study, the World
that's the one.
Anti-Vomiting and Emesis study that Dr. McCallum was pivotal in, published in 2001, was a crossover study that you have told me was biased by patient recall bias and memory. And the design of a randomized controlled trial means there can be no recall bias or memory of the device. And what has happened
Stimulation.
is the great debate causing human device exemptions. The human device exemption is this is the last resort. The goal of the RCT is to make this planned standard of care therapy for gastroparesis because now we have proof that independent of other mechanisms and theories that this electrical stimulation has a clear effect on nausea and emesis that cannot be reproduced by other medications, cannot be reproduced by other surgical therapies, and is clearly indicated for every patient. So in the meantime, as the evidence mounts, we expect within the next decade that when the disease is staged properly and recognized in its exact stage, that people can progress to getting this as first-line therapy.
Brief walk through this. We have done implantation of the device, and many other centers are doing. And this is the device for Nurse Davis mentioned. There are 2 electrodes, and they are on the end of the lead, which is 35 centimeters long. And there is an electrode here, and it has to be put precisely in the wall of the stomach in a 9 and 10 centimeters from the pylorus on a greater curvature of the stomach. So putting this electrode 1 centimeter, just a little bit of this metal is there, and then this is connected with a device which looks like a pacemaker for the heart, exactly the same size and shape. And this device is actually put in an abdominal wall, in a packet which is made there and is connected with, so you can imagine this is in a stomach, there are 2 of them, and then the device is on the top of, in an abdominal wall for communication and interrogation for checking the devices. What Dr. Davis
So it begs a couple different questions, which the audience may want to know is, we're putting needles through the wall of the stomach. So in the meantime, I drop a camera in the inside of the stomach, and I make sure we do not penetrate the stomach. Now, what Dr. Sorosiak has published on over years of research is it really a big deal if the device migrates into the stomach and you find the lead poking through the wall of the stomach? And I will tell you surgically, because of the advent of laparoscopic and robotic surgery with small incisions, this is quite a simple problem to resolve
Good.
without
Okay.
evidence of long-term infection, and that people can safely have small incision surgery, smaller than the size of my index finger,
With a
for
robot.
removal and installation of both of these with very precise suturing and placement with minimal long-term risk of infection when proper care is taken of that surgical wound.
Beautiful. And so this device, how is it controlled from the outside, or is it? Is
Yes.
it? Okay.
Is controlled. You can imagine if this is in a patient and has to be positioned in a packet, which is very visible, we know where it is, then it works on its own. Patient doesn't have any control over the parameters, cannot
Okay.
stimulate, stop, turn off, nothing. Very powerful magnets. If they are somewhere around the patient, we tell them just be careful. Then what we do when they come to see us, we have a programmer, special programmer, and we have the head of the programmer, which goes on a tab. You can imagine this is in a patient's wall inside, is hidden, it's not visible, everything is internal. Then we put on the top of the abdomen, and then I am able to interrogate the device and tell what is the actually impedance, the resistance between two electrodes, because they are 1 centimeter apart, they have to be precise.
So in lay terms, it generates a charge, and the charge tells the vagus nerve to be quiet.
Okay.
And the charge can be changed by the experts, because if the initial charge doesn't work, then the charge can be increased
We have
in
algorithm.
order to, the algorithm to increase the charge there to get the vagus nerve to be quiet. So some people are going to respond to lower settings, and then some people are going to have to dial up the charge in order to do this. You did mention that time was closing. So in respect to the
We have a whopping 6 minutes, though. We're good.
the great debate in the care is that many people in the surgical community feel that cutting the gateway muscle to the stomach, called the pylorus, which actually accelerates gastric emptying, can cause improvement of the symptoms. But this goes back to staging, because by the time they come see Dr. McCallum, the motility is zero in most cases. So even some improvement in motility does not improve nausea and vomiting. And I have colleagues nationwide who swear that cutting that muscle is the key to solving the symptom complex. But what happens from my colleagues at Cleveland Clinic is they admit that all of their patients do not wind up in the hospital. They're outpatient therapies. Now, everyone that comes and sees Dr. McCallum cannot literally leave the hospital. They're losing so much weight that they're in a tragic state of malnutrition. So it's a different stage, and we know that maybe cutting the muscle works when the muscle still can squeeze, and that way the gateway is open. What we've done in this study is said, over a extended period, we do the muscle cutting and the stimulator at the same time, and half the people don't have the stimulator turned on. So what Dr.
But this is for
Sorosiak is an
short
expert in measuring is a real question. Do the people in that off group have any effect on the nausea and vomiting? And what the study says is that the pyloroplasty, or cutting of that pyloric muscle, really does nothing for the nausea and vomiting. And that's where we have seen this in published work, that it is a very significant symptom correlation that can help this become standard of care for gastroparesis.
Catherine, the reason
Yes.
we are here is only to tell everybody that we are here present for patients to feel better. We are
Right.
not giving up on any of them. Even though we have done the stimulation for many years with Dr. McCallum, starting in Kansas with Dr. Forrester, we were able to control the symptoms of the patients, but we could not improve gastric emptying because the door was closed, the pylorus was stuck. So that's why we came up with the idea to add two things together, because in a science, when you show somebody your symptoms are better, but mechanically you do nothing,
Right.
because gastric emptying is not improving, then we decided to go with a double-blind, placebo-controlled study. When we implant the device and we do pyloroplasty at the same time, so patients are getting
Combination.
two procedures at the same time. But that's what is very tricky here, because half of those patients, and nobody knows the device is on or off. They don't feel any stimulation. They shouldn't if everything is working well. So those patients, they go for 3 months without even knowing if device is helping them, or only pyloroplasty, which is, again, open door.
So this
And
is
I-
part of the research that you're doing.
So this is fantastic. Nobody had done in whole entire world. I'll just stop
I'm
here
going
because
to
we are very proud of this.
clarify for a moment. So in looking at the entire body of research, when we talk about the symptoms that people
Yes.
have, we know that pyloroplasty can accelerate gastric emptying, can help symptoms of early satiety, and can help symptoms of abdominal pain. We do know is these people do not get adequate relief of the nausea and vomiting complex. So as we're talking about the two separate disease processes that I debate with people across the country, that is the neuropathy, which causes the nausea and vomiting, versus the motility. And the motility in the end-stage patient cannot be salvaged. Therefore, what we've done with the randomized controlled trial is separated these two groups and said the people in the off position with the stimulator have relief of the satiety and some relief of the pain, but they do not have relief of that cardinal thing that keeps people from going to work, taking care of their children, and contributing to society, which is the nausea and emesis. This is where I make the argument that when more people receive this therapy at accredited centers with experts, that within a decade we will have evidence to make this first-line therapy, not last hope therapy.
Yeah, what we've
Yes,
shown
Dr.
also
McCollum?
is we've studied the brain imaging with PET scanning, and this device, although it's in the stomach, sends a message up the vagus nerve, up the afferent limb, the sensory limb, and goes to the brain. So we send a message which tells the brain, don't be nauseated. It's a direct image, a direct connection to the chemoreceptor trigger zone. So we are helping the stomach locally, but we're also sending a central message. And then we open the pylorus and food empties faster or normally at the end of the day. So we cover all the bases, basically. That's the
And the
big
vagus nerve seems to be the superstar in all of this.
Absolutely.
it is. It is.
It's I don't know when the last time was that we had a good debate on
this.
this.
This is the study design that proves the theory.
Yeah.
So we know, as per Dr. Sorosiak, why the 2001 study started the human device exemption. And we know over 2 decades later from this study group clearly what the mechanism is, because we have a non-biased study that says this is working with the neuropathy in the brain while the pyloroplasty is working with the muscle.
I would love to do this exact same topic 5 years from now, because I know that just, again, healthy debate is where it's all at, but
Oh my
we
God,
literally have
you better
like
believe-
32 seconds left, so we can't, but
Because can you imagine right now what we're discussing with Dr. McCallum, actually Dr. Davis is involved in this too. Now we have another company which oversees this device. Can you imagine this device to be possible to program the way it will work only during the day, during the meals of
No,
yours?
it would be-
So
it would be
during the night
fantastic.
is quiet. More than half of this device, the value of this device is battery.
Yeah.
So we have to save the battery
we have
so
to
it
go.
lasts longer.
I'm sorry,
So
we
this
have
is
to wrap up.
Please do remember
this is the
battery
future.
replacements are minor surgery.
We're going to continue the debate. You all have been tuned in to the El Paso Physician. I'm Catherine Berg.